Welcome to the Homegrown Podcast every Friday morning at 7 a.m. Mountain Standard Time with your host, Dr. Amanda Ryan, DO, MBA, an interventional cardiologist and an expert in her field. This week's topic, obesity and how it affects your heart health. Please help me welcome our host, Dr. Amanda Ryan.
Good morning, Carlsbad, Eddy County, surrounding areas, my listeners in Florida and Illinois and all over the world, hopefully, as we really try to spread awareness about cardiovascular disease. It's a cool morning here in Carlsbad. The cold has been a little disrespectful the last couple days. I'm sure my producer, Danny Fletcher, would agree. We're not cut out for this kind of cold out here. I think it's been like 32, or when I call my husband in Florida, I tell him it's like 20 because I need to exaggerate a little bit. One day there was like, oh gosh, yeah, it's so cold here too. It's 50. I was like, ugh, poor guy, freezing. I just found out some great news this morning that I did want to share with you though. One of my younger cousins has grown up with just a difficult family situation with parents who didn't always make the best decisions, and just a lot of things that made her life a complete challenge. And she has always been an amazing spirit, destined to do great things in life. She's had a lot of her own dental traumas to the point where she's had teeth knocked out and had to have them replaced, and at a very young age. And she really fueled that into a passion to become a dentist. She worked very hard. She went to college with almost little to no support. Truthfully, just really, she does have good extended support system. But to say that she has so much inner strength, she really does. And she applied to dental school right her senior year of college. She did not get in, and it was very devastating for her. She chose to do a master's program. She became published. She spoke at multiple different national conventions. She just really embraced it. She told me that pharmacy school was her backup plan. So she applied to pharmacy school as a backup, etc. And she found out this morning that she did get accepted to dental school. And I'm super proud of her. So Braley Coulter, out here in Carlsbad, and I'm gonna tear up a little bit because you are an amazing young lady. And I'm really proud of you, and so is your entire extended family. And you're gonna set the world on fire and way to really turn a negative situation of your own with your own dental traumas into the ability to help others. I just think there's no greater gift, and I'm proud of you. So that was just a little aside. We're gonna talk about obesity and the relationship to cardiovascular disease today. And I think this is a fascinating topic. And if anyone knows me very well, they know of late night at HV&M, I tend to get in rabbit holes and just start researching everything from, again, Uncle Nearest Distillery and obesity and cardiovascular disease. Soccer, Christian Pulisic is injured. If anybody, that's a little bit devastating for me too, but it's minor, I hope. Christian is who we call Captain America. There's a really great new little, it's not a podcast, it's a documentary, on Netflix. That is Christian Pulisic. He is really a reluctant American hero. He's from Hershey, PA, and he's really painfully shy in many ways, but he is truly the best soccer player that America has ever produced. And so if you get a chance to watch that on Paramount Plus, learn a little bit about him. Again, the World Cup is actually in the United States in 2026, so this is major news. So if everyone, if you have nothing else to do but go down rabbit holes, read about Christian Pulisic, or Tim Weah kicked an assist to Weston McKennie in the Champions League this week. That was Juventus, which is an Italian team, beating Man City, which is a major Premier League team this week. I don't know if everyone, again, knows soccer like I do with my obsession, but the top 4 teams in each of the leagues in Europe then play each year in what's called the Champions League, and that's considered somewhat, of course, the better teams win their divisions in each of their countries, but the Champions League trophy is a pretty big deal every year in Europe as well. So there are several Americans for the first time. I think there are 8 to 10 Americans participating in the Champions League, and that's as represented as we've been ever. So as soccer continues to grow here in the United States, MLS, our own version, is getting stronger and stronger every year. We're probably about the 5th to 6th best league in the world currently. So I encourage everyone who is a sports fan to give soccer a chance so you can learn a little more about it. So how does obesity relate to cardiovascular disease? And obesity medicine, by the way, is a whole specialty. There is a certification that people can get. It's a 1 to 2 year additional residency fellowship for many doctors. So there's a whole lot to cover, and I'm not going to pretend in a 20, 30-minute span that I'm going to be able to cover every single thing about obesity, not even obesity and cardiovascular disease, because there is a lot to say. But what I want to do is implore you to understand better. Again, I tried the same with the smoking cessation. I tried when I explained the stress test. The idea is, again, this is like my word lately, but demystify things. I want you to understand the whys. I've been inquisitive, again, my whole life. I was the why child. Speaking of that, my nephew Stanley, with his... How many ears of corn do you think are out in that field? Like, I don't know, a million? There's probably several million, except why did you think a million? Okay. Oh gosh, there were times when I was like this child, but that's the same kind of child I was. So, having an inquisitive mind, I do better with things when I understand them. And that is really my passion for education of staff and patients and just the communities at large. So sleep apnea, high blood pressure, diabetes, metabolic syndrome, and atherosclerosis, which is really fatty deposits within the arteries. All of these things have an increased risk with obesity, and they all relate heavily to cardiovascular disease. Sleep apnea has been something that we've really discovered in, maybe the last 15 to 20 years. It's become so important. It is actually a leading cause of atrial fibrillation, heart failure, and hypertension, as well as the effects of, difficulty concentrating during the day based on poor sleep patterns, several motor vehicular accidents from people falling asleep secondary to poor sleep patterns, and definitely led to a few sleep divorces in relationships, if not actual divorces, of somebody going and sleeping in the other room or getting tired of being nudged all night to roll over because their sleep apnea is so significant. I will say a little bit there too, that a lot of people, I can't wear the machine, I can't wear the mask, I just can't do it. And a lot of people can't. There are some newer options for how to treat sleep apnea. There are some procedures. There are also masks that just go on the nose now. There are things that are non-traditional. And I encourage you, if you do have significant sleep apnea or are suspicious of that, to really open your mind to seeing a true sleep medicine qualified. It's often a pulmonologist who's done a specific fellowship in sleep medicine to really see what your options are. Because long-standing untreated sleep apnea, another cousin, she knows she's shy, so I'm not going to call her name, but I'm talking to her. Long-standing untreated sleep apnea will give you cardiac effects. And unless you want me to be your friendly cardiologist whenever we're in our 70s, retired, living back in Payne, Illinois with our families, you need to treat your sleep apnea, okay? Hypertension, again, I've discussed it before. We call it the silent killer. For some people, it's silent. For some people, it's not, meaning some people can tell when their blood pressure goes up even slightly, are very sensitive and can really tell if their blood pressure's up even a little bit. There are other people that really can't tell at all what their blood pressure's running. And oftentimes, again, they don't feel good as we start to give them medicines to bring their blood pressure down, because their body is kind of auto-regulated to such a high blood pressure that they have trouble getting used to the blood pressure going down. They tend to blame that on medication side effects and don't want to take them. But again, your risk of strokes is very high, and obesity plays a role. Now, there are thin, healthy weight people that have high blood pressure too. That's true. But I have never treated an obese patient with hypertension that didn't have some improvement with weight loss. Again, my dad, my hero in many ways, with his, for not having to do with his weight, but again, I think I've mentioned he went from 320 to 185 with diet and exercise, and has maintained between 200 and 215 between CrossFit and healthy eating for years on end. And part of that, he was on 4 blood pressure medicines, and now he's on 1. 2 meds for his diabetes, and he's currently on none. So again, weight loss makes a difference. Metabolic syndrome, that's interesting. Got a lot of discussion and stuff in the early 2000s. I feel like, again, the older I get, with my youthful appearance, it's hard for you to believe I was practicing medicine in the early 2000s at this point. But I truly was. I was a student and then a resident back in the early 2000s. Things have changed pretty rapidly about how we viewed obesity and the different treatment options and the diagnosis. But metabolic syndrome is that it's somewhat of a genetic predisposition to increase cardiovascular death that we still holds true today. It's a panel of high triglycerides, low HDLs, which is your good cholesterol, and enlarged waist to hip circumference. And so abdominal obesity, borderline blood pressure, and prediabetes or insulin sensitivity. Again, when I practiced in Hawaii for a year prior to starting my cardiovascular fellowship, after I had finished my medicine residency, which was, again, I've spoken on it before too. Again, as our first year winds down, I hope you guys are going back and watching some of the different podcasts as you get some time over this holiday. Pick something that you'd like to learn about or hear about or know about our practice and read up on it. Or, listen and read so you can kind of find out about that topic. So I did groups back then with a lot of these metabolic syndrome patients. A lot of them were Native Hawaiians, and we were really able to make some differences. It was a year I was there. So I don't know exactly how everything ended up going, but I did some actual group visits of 10 to 20 people that really would amount to a support group for people 25 to 40 years old, let's say in that range primarily, who had these pre-diabetic, borderline blood pressure, lipid panels that were off, abdominal obesity, again, same body type as I have, so I struggle with obesity. Again, I hope I can give you that Oprah type connection, but I always felt like I could relate to Oprah's weight struggle and her comments and the people she would have on about obesity because she dealt with it, continues to deal with it herself. And I think a lot of us felt the same way with her. Same with me. I'm relatable. I've struggled with weight my whole life. Obesity is really a multifactorial disease with a complex pathogenesis that is related to biological, psychosocial, socioeconomic, environmental factors. The heterogeneity in all of these pathways and mechanisms is what works together to lead to adverse health outcomes. So obviously that was a canned statement from one of our obesity magazines that, to break it down, there's a lot of factors, right? There's a lot of factors. And again, as a physician, I've learned over the years too, and again, my father was able to do it primarily with diet and exercise. It has been a struggle still though. Some people, it's just not as simple as eat less and exercise regularly and you'll maintain a healthy weight. It isn't that simple. That's got to be part of the pattern. There are no easy solutions to long-term weight management. It will be hard. It's hard to weigh 300 to 400 pounds, have a BMI of 40 to 45, and be ambulatory after you get to a certain age. That's hard too. It's hard to have an acute heart attack and have limited options for how we can get into your heart's arteries because you're so heavy that it affects our ability to do the procedure. And that extra time may lead to an increased risk of death or poor outcome from your heart attack compared to somebody that does not have particularly morbid or class 3 obesity. Sometimes in life, we got to pick our hard. Obesity is absolutely considered a major risk factor for heart disease, meaning that being overweight or obese significantly increases the likelihood of developing cardiovascular issues like CAD, heart failure, strokes, and atrial fibrillation, sleep apnea, etc. This is well established in medical research. This is not being judgmental of weight, and this certainly is not about looks. This is about health. Some key things we need to think about in the relationship between obesity and heart disease. One is the direct impact. Excess body fat, particularly visceral, again, abdominal fat around the abdomen, can directly affect the heart, increasing inflammation, disrupting blood vessel function, and increasing the workload on the heart, which is a muscle. Obesity often coexists with other risk factors for heart disease like high blood pressure, type 2 diabetes, hyperlipidemia, sleep apnea, which further amplifies your risk and again multiplies. Obesity can contribute to heart disease through various mechanisms like endothelial dysfunction. That's a major thing with a lot of research. So when you look up heart disease and exactly what's going on, I have patients tell me, my dad's cholesterol was always high. He never had a cardiac event. That's true. We don't understand everything. Every patient with high cholesterol will not have a cardiac event, and half the people that have an acute cardiac event have a normal, quote unquote, cholesterol. Again, there's lipoprotein sizes, there's endothelial dysfunction. There's a lot more to the picture than just sometimes in medicine, based on the sheer volume of people that we're trying to help and the research that's being done, we sort of try to one size fits all a situation. So again, we have the whole world on statins, which that should be a podcast of its own, and our opinion on statins to treat cholesterol is, and the pros and cons of such. But again, there's more to the story. The story is deep. The greater the degree of obesity, the higher the risk of developing heart disease. Even a modest amount of weight loss can significantly reduce your risk of heart disease with individuals with obesity. I say that every day to people. We have become a society that wants an immediate answer and an immediate response. If I weigh 250 pounds, I want to weigh 150 in 2 months. No matter how it feels, you didn't get from 150 to 250 in 2 months. Maybe you got there in 5 to 10 years, maybe 15 to 20 years, but you didn't get there in 2 months, and you're not going to get back to that goal in 2 months either. I really encourage people, as part of a plan for a healthy weight loss journey, to set small goals. Some of them scale, some of them non-scale. Those of us weight loss champions who have done Weight Watchers and all other plans out there over the years, we know those as NSVs, non-scale victories. Get those non-scale victory pants out. That is the first step of, if you're wearing an 18 and you're trying to get to a 16, put those 16 pants out. And when you get to those size 16 pants that pull up over your hips and button without you laying on the bed, I don't know if I'm the only one that does that to see if my pants will fit. But if they can zip, then they fit in my high school world anyway. My dad used to say, did you paint those pants on? Or how did you get those on? I was like, I laid down on the bed, zipped them up, and I thought they worked just fine. So here we are. Oh gosh. Again, though, I'm sure with me as well as anybody, if we could all be the size we were the first time we thought we were fat, quote unquote, which again is not a term we should even use to describe people, but ourselves either. It's really derogatory and defeating. But you know, those high school years, you think you're fat. Again, I think I weighed 145, 140, 145, and I definitely thought I was obese. Again, so set some non-scale victories. You know, it don't get so glued to the scale. The scale is interesting. When I'm not eating well and I'm not on a path of positivity with my overall cardiovascular health journey, I avoid the scale. And on this journey again of weight loss and the non-scale victories and the, you know, again, setting small goals for yourself and kind of making sure that you celebrate your successes as they come. Again, we can avoid the scale totally when we're not on a good journey, or at least that's how I handle it. But then I can become a little obsessed with it, weighing several times a week whenever I'm on a good journey. And the truth is, you know, once a month, every couple weeks is sufficient. Your weight's not going to fall off you typically in a manner that it's good for you to be weighing that often. So it's not good to avoid the scale for, you know, a year when you know that you're not really doing a good job, but it's also not good to become obsessed with the scale. The global obesity epidemic is well established, with increased in obesity prevalence for most countries since the early 80s. It's just been continuing to increase, which again contributes to incident cardiovascular risk factors, which we've talked about many of those. Again, type 2 diabetes is almost exclusively a disease of obesity. There are some type 2 diabetics, and again, more out here than I've seen in other places, that are not necessarily obese with type 2 diabetes, but most type 2 diabetics are obese. And most of them, at least in the beginning, could control, their diabetes with diet and lifestyle modifications. Studies that quantify fat deposits, including ectopic fat, support excess visceral adiposity as an independent indicator of poor cardiovascular outcomes. So again, the increased abdominal fat does increase our risk of cardiac disease and poor outcomes. How do we define obesity? That's another important topic. BMI, and there's times when we say, oh, BMI is, it's not realistic. It's, we've gotten larger as a society, et cetera. And there is some truth to that. However, so I do think maybe the standards should be adjusted a little bit. But many of the issues with obesity we're talking about when we're getting to that obesity phase, which is going to be a BMI of greater than 30. And the truth is, if our BMI is greater than 30, we do have an increased risk of cardiovascular disease. And I don't think that changing the standards, again, this is a typical American attitude, if we're heavier than we were before, then we should just change the standards for obesity. The issue is we have a lot of research linking BMIs to cardiovascular and other obesity complications. So you got to be careful. If you were to change your standards, then your research that studied it to this point would be null and void. Sometimes change is necessary, and we may end up changing the standards a little bit over the years, but you have to understand the implications of changing some of those. It would take us years to get the new research then. About 49% of the world's population is qualified as obese, which is about 4 billion people. Okay. CAD assessments in people with obesity can be a challenge. The baseline EKG can be influenced by obesity. Patients with obesity have impaired maximal exercise tolerance capacity, so it may be difficult to get a stress test on those patients. The echocardiograms, which is ultrasounds of the heart that we do in our office, and many of you have had, are difficult to see well whenever you have a lot of obesity. CAT scans can be difficult to really separate what's going on with your coronary arteries in people that have obesity, and heart catheterizations as well as any interventional procedures can become more difficult and higher risk with obesity. Well, I hope I have your attention. Maybe a little bit depressing, for our obesity talk so far. So we're all heavy and we're all going to get heart disease. So here we are. What works? Let's focus on something a little more uplifting. We've decided that we understand obesity is epidemic worldwide, and particularly in the United States. In Eddy County, our rates are a little bit higher than average. We're about 40%. Eddy County, Chavez, Lee, we're three of the top 6 counties for obesity in New Mexico. Our rural area definitely has a higher prevalence. Thank you, Tammy Wacker with Partners in Heart Health and Advanced Heart and Vascular Center of New Mexico for getting me some of that data. And we'll share that with Danny so he can show some of those slides on our obesity numbers. They're high, again, 40% high. But again, so we realize it's an epidemic. We realize there's a link between obesity and cardiovascular disease directly, as well as all of the increased secondary risk factors for cardiovascular disease and death that obesity plays a role in. So again, this could be a 20-part series just discussing obesity. So we're glossing over some of these topics. If it interests you, go look it up. Go down that rabbit hole so that you can understand enough that it helps you make a difference in your journey. Lifestyle modification with associated weight loss improves the diagnostic components of metabolic syndrome and associated pathophysiologic abnormalities such as systemic inflammation, endothelial dysfunction. Intervention with medical weight loss have not necessarily demonstrated a clear reduction in CAD rates, though. It's kind of interesting. Lifestyle modifications with weight loss do help a lot of things, definitely. But the direct link to decreased cardiovascular deaths and prevalence of coronary artery disease have been proven with bariatric surgeries. They have not really been proven with other medical therapies or lifestyle modifications completely. The FDA recently approved semaglutide, Wegovy, to reduce the risk of heart attack, stroke, and cardiovascular death in adults who are overweight or obese and have cardiovascular disease. This is a GLP-1 agonist that mimics a hormone that decreases appetite. It should be used in combination with a reduced calorie diet and increasing your physical activity. These medications are a game changer for the weight loss industry and for the way we approach obesity. Now, I always tell my staff, we don't want to be the first people to adopt things. We don't be the last people. Example, there's something that I learned from my mom, but back in the 90s, when I had my own serious medical condition, my mom knew enough to hesitate me using opioids. And as a physician in a non-acute setting, I never prescribed an opioid. There was something I knew in my heart that wasn't the best approach to chronic pain. And I stayed away from prescribing it for chronic pain. Acute pain is a different situation. But for chronic pain, I stayed away from it. As the research kind of developed in front of us, we realized that there are a lot of negative effects of taking long-term opioids, And I'm grateful as a physician that I didn't go down that path. I think it would have harmed my patients in the long run more than it would have helped them. So when semaglutides first became, everyone's like, oh, Wegovy, Ozempic, taking it. And then some of my diabetic patients were frustrated because quote unquote regular people or non-diabetics who were overweight were taking these medications. And we knew that they were helpful for diabetic patients, but are they helpful for non-diabetic patients? And what exactly is going on? And a lot of my diabetic patients, by the way, was helping control their sugars. They weren't necessarily losing weight on the medications. So there's just so many different factors that I was kind of like, what exactly is going on with these medications and where are we going to end up with them? And I don't have the answer still. And I would say we're still relatively early in this whole GLP-1 agonist, which, by the way, there's so many armchair experts on these drugs now out there too. You need to be careful of what you're really reading. Who's giving you these medications? Do they understand the long-term risks, benefits, et cetera? And that's the reality. I'm not sure any of us know the exact long-term effects of some of these drugs. If we're taking them for weight loss primarily, how long should we stay on the medications? What is the proper dosing? I have a friend who is a physician who is doing very well on one of these drugs combined with aggressive lifestyle modifications. And she has gotten to her goal weight and she is on a very small maintenance dose, which I think she feels like it is appropriate to stay on that long term. But again, we need to watch these long-term side effect profiles of these medications too. However, we know the long-term implications of morbid obesity. We already know those. So in some ways, life is a risk. You have to understand that there are risks and benefits to every decision that you make. I encourage partnerships with my patients. I encourage partnerships with you. I encourage partnerships with the community. This is part of our mission in all of our different businesses. In this partnership, as a patient, you've got to understand things. We cannot go back down that same opioid path that my doctor gave these to me and said they would help, so I took them. We can't do that. You've got to have some education of your own about the different risks and benefits of the medications. Again, GLP-1 agonists mimic a hormone in the body that helps decrease the appetite and along with other mechanisms leads to weight loss. The New England Journal published an article that semaglutide was found to decrease the risk of cardiovascular events by 20% amongst those over 45 who had pre-existing cardiovascular disease, were overweight, or had obesity who were non-diabetic. This is life-changing for many people. This is great research, but as always, while more research is needed to better understand this and look for the impacts in more typical groups of cardiovascular disease patients, randomized placebo-controlled clinical trial looks very promising. May also impact your other risk factors, again, blood pressure, cholesterol. Specifically, the brand Wegovy is now the first weight loss medication to be approved as a prevention treatment for adults with cardiovascular disease who either have obesity or are overweight. But the FDA cautioned it should be used along with a reduced calorie diet and increased physical activity. And again, if you want to read about that, the select semaglutide effects on cardiovascular outcomes in people who are overweight or obese. More to come on these drugs, and next year, maybe towards the end of the year, as we'll have some more research coming out, I would love to do a whole discussion on semaglutides. What are some lifestyle changes that we can do as well? Limit foods that are high in saturated fat, such as fried foods, added sugars, such as table sugar, honey, and sweets. Choose lean meats. Trim visible fat off of your meat. Use lower fat cooking methods like baking, broiling, roasting, stewing, steaming. Use liquid plant oils such as avocado, walnut, peanut, flaxseed. Avoid hard fats at room temperature like bacon grease, shortening, margarines, Avoid tropical oils like coconut, palm kernel, animal fats that are in butter and lard, and partially hydrogenated fats. Choose and prepare foods with little to no salt. So again, as a cardiologist, a very common question I get on a daily basis, what food should I eat? What diet should I follow? What is the best diet? The Mediterranean diet, the DASH diet, South Beach, intermittent fasting, I think a lot of those type of diets are going to have some very positive cardiovascular impacts, as well as have weight loss as part of them. A plant-based diet that is low in sugars and saturated fats is definitely the way to go. It's hard to follow for many of us that have grown up in Western societies, but it has by far been proven repeatedly to be advantageous to our cardiovascular health. Exercise more. All right, my last part of this morning PSA about obesity and cardiovascular disease is exercise well. Make exercise a priority in your life. Make it a planned activity. If possible, walk the entire or part of the distance to work. Get an exercise buddy. I've always done better when I had a buddy. My mom's my current exercise buddy. We're out there walking together, and when we fall off the wagon, it tends to be together. But sometimes I'm more the encourager, sometimes she's more the encourager. Have a plan. Park at the end of the parking lot. Walk to the store or the office entrance. Use the stairs if you can. If you have a desk job, walk in the halls sometimes. Not my staff, we don't have time for exercise at work. I'm just kidding. We get plenty of steps at HV&M. Do leg lifts while you're sitting at your desk. Do something outside on the weekends. Plan a hike or a bike ride. Again, I've also discussed this in previous podcasts. There are very few people that can do absolutely zero form of exercise. If you see our Paralympic athletes every 4 years in their competitions and the disabilities that many of them have, and then you hear the excuses that most of us make on a daily basis about why we can't exercise, the truth is we don't want to. It isn't that you can't, you don't choose to. I want you to choose yourself. I held hands with a patient yesterday in our Artesia clinic who had came to me for an elevated blood pressure, quite elevated triglyceride panel, low HDL, borderline diabetes, middle-aged, strong family history of heart disease. I held her hands and I said, I'm like you and you're like me. And together we're going to make a decision to decrease our cardiovascular risk and lessen our chance of having a heart attack or a stroke, or we're going to escalate those risks by our lifestyle choices. I treat end-stage disease, people having heart attacks, people needing open heart surgery, people that are about to lose their limbs, cleaning out the plaque in their leg arteries, because that's what I'm often faced with. But make no mistake, prevention is my passion. And I don't often get a chance to really talk to somebody about prevention. And I had an office full of patients yesterday when I took a few extra minutes to really discuss prevention with this patient. But she really spoke to my heart, and I hope I spoke to hers. So take time for yourself. This weekend, I also get an amazing opportunity that I will share on my podcast, The Zoom. I'm actually speaking at the Critical Limb Ischemia Foundation has a annual scientific meeting in El Paso, and I'm going to talk about our rural cardiovascular program there. I'm also going to be a panelist while Dr. Lake Raja, who I've spoken about before, does a case that's transmitted all over the world to many of our colleagues via Zoom, showing him working on a leg blockage and what's really involved in that in someone that's truly at risk of losing their limb. So again, which doing peripheral procedures on patients that are obese has a much higher risk. It's just a much more difficult procedure. So the point of that was to say I'm excited about talking about our rural cardiovascular program this weekend, but also to pull it in with the topic, which is that obesity has a high risk in cardiovascular disease, and we need to do what we can to change that risk. Have a great week. Next week, we'll be closing out the year. It's been an exciting year for my homegrown heart, and I appreciate you guys all supporting.